London. We had originally planned to come together here in London to meet for the 5th clinical update sleep. Instead, now we are going to talk about the clinical update sleep during a webinar. And the webinar being actually, yes, of course, in times of the COVID pandemic, the replacement for coming together. It's a virtual briefing. Let's hope we can meet all again in the new year in person at the Royal College. We have planned to postpone the event with all the speakers to March. So today, just really a short virtual briefing of 2 hours with some hopefully very interesting topics for everyone. So a few housekeeping points. We will have a Q&A chat box later coming up on the side. Get used to this, please. This is where you need to post your questions, that you can put to the chairs, and the chairs will then discuss with the speakers. The webinar will be recorded, and please afterwards fill out your evaluation survey, which the link will be posted for, so that you can claim your CPD points. But now, welcome to the Clinical Update Sleep. Welcome to the update webinar in 2020. And we thought that this year we put the topic under the label, The Sleeping Beauty. Now here, this is the Royal Dalton tiles, which are actually hanging outside my unit in St. Thomas Hospital from around 1900s. It's a mosaic tile. And you can see here the beauty of sleep, which is metaphorically speaking, of course, in many ways interesting. We all have certain interests. We all enjoy the multidisciplinary aspects of sleep, and we all come from very different backgrounds to think about what is happening in sleep. Sleep still has a lot of answers to question. There's from really almost mysterious influences of lymphatic systems. Now some news in the scientific community, down to the everyday problems that we may or may not have experienced during the pandemic lockdown with insomnia. So sleep has to offer something for every faculty, but also metaphorically speaking, maybe to describe the state that we're currently in, being held really at ransom by the terrible COVID pandemic with national and international lockdown scenarios, where we are waiting for the final kiss to be really relieved of this pandemic, which may not, hopefully, a vaccination over the course of next year will bring to us. So in many ways, the Sleeping Beauty is a metaphor that we might all find of interest, and we are gonna try to fill this kind of interest with an packed program over the next couple of hours. We're going to start with a slight change in the program. Dr. Martino Pengo, who kindly has declared himself available to talk today, he is on call later and therefore goes first, followed then by Dr. Laura Perez Carbonell, who will talk about COVID and sleep with some data from the British Sleep Society surveys. We will then be joined by Professor Dieter Riemann from Freiburg in Germany, who will talk about insomnia and mental health, the role of hyperarousal, and eventually we will come to some highlights that I will present from the special issue of the Journal of Thoracic Disease that was due to be published with the original event this month. It is published, it is open access since yesterday, so I'll talk about this a little bit later on. Eventually, we will have some more time for questions and answers, which Esther Schwarz from Zurich and I will try to address. And I hope you will all enjoy this, and by the end of the day have some time to have developed further ideas and concepts around sleep. So thanks for joining, and also thanks for all the sponsors that would have originally joined us at the RCP, but now are going to hopefully join in March. So please save the date. At the moment, it stands at the 19th of March 2021. Look out for our web pages. I'm sure there will be announcements whether this is also going to be, as it looks more and more likely at the moment, in a virtual space instead of in the venue with a face-to-face meeting. But now, without further ado, I would like to hand over to the first speaker. So Dr. Martino Pengo is a colleague, former student, research fellow, and friend of mine who has worked with us for many years in London, and then after finishing his PhD has now taken up a consultant post with Professor Parati at the University of Milan. His background is cardiology, but he's got a deep interest in sleep, and he's published earlier in the year a paper in the European Respiratory Journal on the effect of CPAP therapy on blood pressure, a meta-analysis. He's going to talk about this and a worldwide collaboration. Martino, I hand over to you.
Thank you, Jorge, for your kind introduction, and it's a pleasure for me to be here, although I was expecting to see you all in person, but I guess that we need to get used to this sort of online meetings, as I am personally getting used to the cathedral square in Milan that you see in my first slide, which is completely empty. This photo was taken in March this year, and usually this square is very, very busy, and unfortunately we need to get used to this kind of situation, hopefully for not a long time. Now I'm going to talk about a topic which is certainly has been well discussed in the past decades, which involves the relationship between sleep disorder breathing and cardiovascular diseases. Now, my focus, I'm personally involved in cardiology and hypertension in particular, and the link between sleep apnea and hypertension, as you know, has been well studied. But in medicine, as all of you know, is always difficult to establish when there is a causal relationship between two phenomena, or the association is not linked by a causal relationship. So before going through some studies and before going through the meta-analysis that we have published this year in the European Journal of European Respiratory Journal, I was very interested in discussing briefly the association between sleep disorder breathing and hypertension, and ultimately cardiovascular disease, because when we talk about translational medicine involving different fields of medicine, it's always important to establish whether we are talking about two phenomena that are linked together, and it's important to understand which is their relationship. Now, this gentleman here, Sir Austin Bradford here, defined some criteria during his studies on the relationship between smoking and lung cancer. Some criteria which are now well known as Bradford-Hill criteria to establish whether two phenomena are related with a causal relationship. And I just wanted to go through briefly these criteria regards to the association between sleep apnea and hypertension, because although it seems all clear, there are some aspects that needs to be discussed a little bit, are not so clear and so evident. Now, one of the criteria is temporality, for example. So the exposure must precede the onset of disease. In a nutshell, people with sleep disorder breathing should develop hypertension later in the years, and this has been demonstrated in some cohort studies. This is, for example, these are the data from the Wisconsin sleep cohort, which is one of the largest cohort of patients with sleep disorder breathing. Patients have been followed up now for eight years. And as you can see, the odds ratio suggests a correlation between the presence of sleep disorder breathing at baseline, diagnosed with a sleep study, so not with questionnaires only, and the presence of hypertension at follow-up, even if the data were adjusted for the major confounders, which are frequent, as you know, in patients with sleep disorder breathing. So we can say that certainly temporality is something that is there and is present in this relationship. And we can say the same thing for the second criteria, which is a biological gradient. So if there is a causal relationship between two phenomena, then those response should be seen. And in fact, in the same studies, in the same cohort of patients, when you plot, as I've done in this the slide adjusted from the original paper, the New England Journal paper, you see a trend in patients with mild and moderate severe sleep apnea. The odds ratio are increasing. Again, even if the odds ratio are adjusted for the main confounders. So certainly the first two criteria were met in a way. The third is consistency. So obviously, if you want to determine a causal relationship between two phenomena, you should replicate the same findings in different populations with different ethnicities, for example. So this has been done certainly in different populations, American and Spanish, but in other, the same findings have not been replicated clearly. So this can depend. I mean, there are many reasons that can explain this issue. Certainly, the phenotype of the patients are different, and the confounders sometimes limit the presence of a clear relationship between two phenomena. But certainly, it's important to note that the consistency is not 100% sure, let's put it that way, for all the studies that addressed this issue. Now, the strength of association is another important point. Obviously, if the larger an association between exposure and disease, the more likely it is to be causal. Well, this is a tricky point for the relationship between hypertension and sleep apnea, because there are many confounders. As you know, patients with sleep disorder breathing are often our high cardiovascular risk for other reasons, for example, obesity, and therefore are prone to develop hypertension regardless the presence of sleep disorder breathing. So this makes the strength of association not so evident in many studies. Other issues that can be related to this are certainly, as we said, the comorbidities, the lack of matching with some confounders, and also the assessment of blood pressure. Now, blood pressure, as you know, is a very variable phenomenon. If you rely only on one blood pressure measurement taken in the office during a consultation, well, it doesn't tell you much about the blood pressure profile of a patient. We have learned in cardiology, but in sleep medicine in particular, that nocturnal hypertension is an important marker of cardiovascular consequences. And therefore, many studies and many trials published several years ago focused only on office blood pressure, neglecting in a way the fact that, again, 24-hour blood pressure can help defining slightly better a blood pressure profile of a patient. So this is actually very important to consider, in particular when we interpret the results of the studies. Another important criteria is biological plausibility and coherence. And I I believe that with regards to the association between sleep apnea and hypertension, several links, biological links and pathways have been demonstrated both in vitro and in vivo, involving basically intermittent hypoxia and therefore the stimulation of the chemoreceptors, but also the fragmentation of sleep due to the arousals caused by apneas and hypopneas. All these elements determining a sympathetic activation and an overall production of vasoconstrictors, which are the most important factors related to the development of hypertension. So I think that with regards to biological plausibility, we can be quite happy because it's something that has been demonstrated quite clearly. Now, specificity is another very interesting criteria. If the exposure causes only one disease, and as we discussed briefly before, it's very difficult in this case to demonstrate this, given the presence of many confounders. However, this nice study from Renaud Thomizier and the group of Grenoble tested this hypothesis, recreating sleep apnea, if you want, or at least intermittent hypoxia in 12 healthy non-smoking normotensive subjects. So what they did basically, they asked the subjects to sleep in a tent, as you see in the figure, recreating intermittent hypoxia, obviously without airway obstruction, that's for sure. But the traces that you see on the right-hand side of the figure of the slide are quite similar, and we can say that a degree of intermittent hypoxia has been induced in such patients using this method. And the results show that compared to pre-exposure, during the exposure to intermittent hypoxia, this subject developed nocturnal hypertension, which is very interesting from my point of view, because again, nocturnal hypertension is a parameter very strongly related with cardiovascular events. So the findings of this study are quite interesting to me and confirm that there is a specificity in this kind of relationship. We can increase blood pressure if we induce intermittent hypoxia. Last but not least, reversibility. We know that there are several ways to treat sleep disorder breathing: CPAP treatment, MADs, weight loss, surgery, electrical stimulation, etc. Now, according to, if reversibility is true, if we treat sleep apnea, we should treat blood pressure as well. Now, this is the tricky point, because if you have a look at the forest plot in this slide, which comes from a meta-analysis published by the group of Fava from Verona in Italy, the forest plot is not very regular, if you want. There are studies showing a clear benefit of CPAP treatment on blood pressure, others not showing any benefit at all, and others, on the contrary, showing that passive treatment or control group is even better than CPAP with regards to blood pressure lowering effect. Now, this huge variability ends up with an overall positive effect of CPAP on blood pressure, but very modest in absolute numbers. It's about 2 millimeters of mercury with regards to office blood pressure. Now, have a look at this forest plot. Pretty much the same thing, okay? Quite variable in terms of the results of the different studies. And the absolute numbers are pretty much the same. So a beneficial effect of 2 millimeters of mercury in the active group compared to the control group. And this is a meta-analysis done on beetroot juice on blood pressure, the effect of beetroot juice on blood pressure. So at the end of the day, 2 millimeters are not that much, if you want, although they correspond in the long term to an improvement of the overall cardiovascular risk profile. But I think that we can do more and at least understand why some patients are not experiencing any benefits in terms of blood pressure lowering effect from sleep apnea treatment. So in a recent review, we put together all the meta-analysis done in the last years, and the overall effect is pretty much the same: 2 millimeters of mercury for both diastolic and systolic blood pressure. And in fact, the guidelines at the moment do recommend the treatment of sleep disorder breathing in patients with hypertension, but without really telling us which are the phenotypes that are experiencing a greater beneficial effect in terms of blood pressure decrease and therefore an improvement of their cardiovascular risk profile. And this is what we should do, actually, and what we are doing in other kind of diseases. We need to understand the right phenotype for the right treatment. This is not so easy, but in all the patients that we see in clinics, we should at least have an idea on which patient we are expecting a greater effect of sleep apnea treatment on blood pressure in this case. So the scope of our meta-analysis was exactly this: to try to identify specific subgroups of patients that can respond better in terms of blood pressure reduction. We have included only RCTs in this meta-analysis, evaluating the effect of either CPAP or MAD against control group, but we also included patients with an active control group treatment, so comparing, for example, head-to-head CPAP versus MAD. And we try to define the blood pressure lowering effects for each phenotype that we identified in our meta-analysis. So starting from more than 4,000 studies, we ended up with 68 RCTs. As you see from this flow chart, most of them were regarding CPAP treatment versus control group, or either sham or no treatment. The results overall were quite consistent with what the other colleagues found in other meta-analyses. So overall, the effect was around 2 millimeters of mercury for both diastolic and systolic blood pressure. Although when we analyzed 24-hour blood pressure, the effect on nighttime was great. It was around 4 millimeters of mercury, which again is something to be taken into consideration when we see a patient, for example, with a non-dipping profile in their ambulatory blood pressure monitoring, or with nocturnal hypertension, for example. Then we tried to evaluate some specific phenotypes, and we did see that younger patients tend to experience a greater improvement of blood pressure whilst on CPAP treatment in this case. So around 4 millimeters of mercury compared to 0, so no big improvement overall in elderly patients. And this is again an important finding, if you want, because in the asymptomatic patient with moderate sleep disorder breathing, we should understand whether we are encouraging the patient to use a device like a CPAP machine or MAD to improve their cardiovascular outcome. Blood pressure at baseline was another important predictor. So the higher blood pressure at baseline, obviously the greater was the improvement at follow-up. This could be obviously an effect related to the regression to the mean factor. However, as you know, RCT with a control group can minimize this effect, which is less relevant compared to other studies. So this with regards to systolic blood pressure, diastolic blood pressure, same finding with regards to age. We did see some interesting data about the minimum of oxygen saturation that we see at baseline. So the more severe hypoxic burden, if you want, the greater improvement in blood pressure. And this was something that we have seen also when we compared the data of studies assessing patients also with 24-hour blood pressure monitoring. So an oxygen saturation less than 77% at baseline sleep study was associated with a massive improvement of blood pressure at follow-up around 7 millimeters of mercury. So certainly something clinically relevant. And this was seen also for diastolic blood pressure in the 24 hours. Again, another big improvement of blood pressure whilst on treatment in those patients with a severe hypoxic burden. So in this slide, we tried to group all the relevant and significant association in the phenotypes that we identified. And overall, what we can say that probably, because this has not been tested in an RCT, the best patient to treat in terms to, in order to expect a greater improvement in blood pressure whilst on CPAP in this case, is a young patient with uncontrolled blood pressure baseline and with a severe hypoxia related to the sleep disorder breathing. So this is a phenotype that potentially could help us discriminating in our patients seen in clinics which are likely to respond more in terms of blood pressure reduction. Now let's try to interpret these results a little bit, considering the evidence present in the literature. Now these are the data from the SAVE trial that you certainly well know is the largest RCT published so far, comparing the effect of CPAP on outcomes, on cardiovascular outcomes in patients with sleep disorder breathing. Now, you know that the study was not successful, unfortunately, to demonstrate a beneficial effect of CPAP in these patients. And if you have a look at blood pressure in those patients, well, you see an initial decrease of blood pressure after the first months of treatment, but at the end of the treatment, in this trial, blood pressure was pretty much the same compared to baseline. And interestingly, the median age of the patient recruited in the SAVE trial was around 60 years. So this again, in a way, confirms our finding that if you try to treat patients with sleep apnea, elderly patient, perhaps with other cardiovascular comorbidities, it's difficult to expect an improvement of blood pressure, and probably, as blood pressure is a proxy in a way to tell you if the patient is improving his or her cardiovascular risk profile, we cannot expect to see a relevant effect on cardiovascular event as well. So another important topic is, as we discussed, the hypoxic burden. This has been tested in some cohort of patients by the group of Harvard. So they basically calculated the degree of hypoxia related to apneas and hypopneas. And as you see in this figure, those with more severe hypoxia tended to survive less and to die for cardiovascular events compared to patients with a no or only mild hypoxia related to sleep disorder breathing. So again, another possible demonstration that hypoxia, other than AHI, the classical parameter that we consider for sleep apnea severity, is something to look at if we want to perhaps better interpret the results of your sleep study and to understand the best treatment for your patient. And another important point is, as we discussed, blood pressure at baseline. In patients with resistant hypertension, we know very well from the data published by the Spanish group, the HYPARCO trial, on patients with resistant hypertension, the benefit was more significant than patient with stage 1 or stage 2 hypertension. And in this recently in the Journal of Hypertension was published a follow-up study of the HYPARCO patients, and the effect was maintained over time. So again, this a specific cohort of patients with resistant hypertension are more likely to benefit from CPAP treatment, in this case, to reduce their blood pressure. However, there are some cases in which we don't see an improvement in blood pressure when we treat patients with CPAP, for example. This study showed us that we must pay attention to nocturnal hypertension, because in some patients we can even increase blood pressure at night whilst on treatment. And this can have a potential impact on their cardiovascular outcome as well. In fact, there are some factors that are associated with increased blood pressure in patient treated with sleep apnea. Think about, for example, leaks. Mask leaks are frequent in some of the patients that we see in clinic. Well, they can cause discomfort to the patient. They can cause arousals, awakenings, and disturb sleep in a way. So when the patient is awake, obviously blood pressure goes up. And the same thing applies for the pressure that we prescribe for our patients. So if we overtreat the patient with excessive pressure, then the risk is to hyperinflate the chest, to cause discomfort again, awakening as well. On the contrary, if we undertreat the patient, well, we have residual sleep apnea that we know is an issue. And this can also explain why some patients do not exhibit an improvement in their blood pressure profile at night in particular. Now, we have tried to test with Jörg and other colleagues in London this concept, and in fact, we have seen that if you hyperinflate obese patient with sleep disorder breathing, you see an activation of the respiratory muscles, you see an increase in blood pressure, and you see an overall discomfort, a subjective discomfort complained by the patient. So it's something to look at when we titrate our CPAP devices. And of course, the issue of compliance is something that we cannot forget. We have learned this from the Hyparco trial, that CPAP correlates with changes in both diastolic and systolic blood pressure. And we shouldn't forget about this matter, because even in the SAVE trial that we have seen before, compliance was not so good. So it's something to always to consider when we see patients at follow-up, also with regards to cardiovascular prevention. So to try to sum up what we discussed, we have two patients, same severity of sleep disorder breathing, but very different phenotypes. Now, probably now we have more elements to say that probably Jane would experience more benefits in terms of blood pressure reduction rather than Albert, because of the characteristics that we have seen. So blood pressure at baseline, hypoxia burden, age, etc. Of course, this needs to be tested in a randomized controlled trial to demonstrate that this hypothesis is true. So at the end of the day, if we want to do cardiovascular prevention in our patients with sleep disorder breathing, on top of treating their sleep complaints, of course, we need to clearly understand the phenotypes of our patients and investigate all the potential variables that can in a way drive our clinical practice to prescribe the best treatment, again, to treat their symptoms, but also to have an impact on their cardiovascular risk. And it's important to remember that sleep apnea is just one of the risk factors. There are several other risk factors that should be under control if we want to do properly cardiovascular prevention. To try to sum up what we briefly discussed today, I guess the association between sleep apnea and hypertension is well documented. There is a potential causal relationship, as we have seen, although not all criteria are fulfilled. Treating sleep apnea does not always mean reducing blood pressure. We have seen that. Some phenotypes can help us understanding who can benefit the most. And precision medicine overall, also in this field, is crucial to ensure that our patients are properly treated and ensure a proper cardiovascular prevention. I'll finish mentioning what Jörg mentioned before. We are now trying to develop an individual patient data meta-analysis with many centers around the world that kindly joined our project, which is named Andante Research Group. At this stage, we are collecting the data and starting to build up the master database and hopefully start the analysis soon. So it will be interesting to see if our findings are confirmed in an individual patient data meta-analysis. And of course, we will keep you updated in the future about further progresses. And I thank you for your attention.
Thank you very much, Martino, for this great talk and the overview on this wide topic. You took us from thinking about causality over the pathophysiology, explaining this relationship and treatment effects, and also led us to the area of personalized treatment, which we are currently in sleep medicine. Thank you very much for that. And I would like to use the time to ask you a few questions that have been asked by our public. And one of the questions was, how do these 2 to 3 or 2 millimeters of mercury translate into a cardiovascular benefit, or what long-term effect on the prevalence of cardiovascular or cerebrovascular incidents this might have? Are there data?
Yeah, absolutely. Of course, we have data about this, not in patients with sleep disorder breathing, because unfortunately we don't have this long follow-up studies in terms of sleep disorder breathing and cardiovascular prevention. But certainly in all the previous studies in cardiology investigating the effect of antihypertensives, we do know that 2 millimeters of mercury correspond to a significant improvement in cardiovascular prevention that goes from a reduction from 5 to 10% of cardiovascular events at follow-up. Of course, this varies a lot according to the type of the patient, so it's difficult to generalize the concept. But overall, there is a clear dose-response relationship, if you want, between the millimeter of mercury that you manage to reduce in a patient and the reduction of cardiovascular events in the future. So yes, there is, of course, not specifically in patients with I mean, there are no data so far in patients with sleep disorder breathing and hypertension, but hopefully we'll manage to get them soon and address this question as well.
Yeah, thank you. And another question was, what is the hemodynamic effect of reducing the left ventricular afterload by reducing the blood pressure by a few millimeters of mercury? And what type or what kind of effect is of the intrathoracic pressure swings of up to 40 or 60 millimeters of mercury during hypotonic events?
Yeah, so this is an interesting question. I actually will need a half an hour to go through the various response. Well, of course, it's very difficult to identify the contribution of the pleural swings to blood pressure changes, because in this patient, as we know, and as we have seen in the slides, there are several determinants that contribute to changes in blood pressure. However, I remember studies done, physiological studies testing this hypothesis and confirming that independently from other factors, for example, intermittent hypoxia, testing also the degree of sympathetic activation. There are some microneurographic studies testing this hypothesis. There is, in fact, a correspondence between the pleural changes and sympathetic activation and blood pressure improvement in such patients. So again, yes, this is absolutely true. Always difficult to discriminate the the degree of contribution of that specific aspect, in particular on left ventricle function. But yes, it's absolutely an important effect that we are currently studying actually in patients with heart failure, which, as you know, do experience a very different hemodynamics compared to patients with a preserved ejection fraction.
Yes, so the same might be true, that it depends on the type of patients you look at, how the hemodynamic effect will be. You have shown very nice that there are different types of study designs that we need to perform to answer these questions and to identify potential predictors of blood pressure response. And we are looking forward to see the results of the individual patient data-based meta-analysis, and I'm sure that will give us some more insight. There are a lot of more questions, but we have, in terms of time, we have to move forward. But one very important, or the most important question of all, will be how do we advise patients in terms of blood pressure or treatment recommendations when we think of the blood pressure reduction, and how much are symptoms in line with that. So, but maybe we can discuss this question that is of big interest, and we'll need a bit more time later in the Q&A.
Absolutely.
If that's okay for you.
Absolutely.
And then now it's a pleasure to introduce our next speaker, Dr. Laura Perez Carbonell. She's a well-trained and internationally trained neurologist working at the International Sleep Lab of Guy's and St Thomas's in London, so a colleague of Jörg. And she will talk about how the lockdown and the COVID-19 pandemic influence different aspects of sleep. And her data are based on a population-based survey, including different populations, also key workers and patients with suspected COVID-19. And now the stage is all yours, Laura.
Thank you, Esther, for the kind presentation. Thank you, everyone, for joining us today in this webinar, and to the organizers for the invitation. I'm going to talk about a study that we've done with some colleagues at the Sleep Center at Guy's, but also with colleagues from the British Sleep Society, in which we wanted to look at the impact of the pandemic that we are living, that it's been having on sleep. As you all know, following the outbreak of SARS-CoV-2 in December in China, and the declaration of a pandemic in March this year, public health measures were adopted worldwide, and this was done at different levels, including things like track and tracing, self-isolation, quarantine, social distancing, but also nationwide lockdowns were implemented, including in the UK. And we know from previous, more or less similar situations that psychological consequences are significant in these circumstances, but there's always been very little focus on sleep. At the time of developing this work, there was some evidence of the impact of COVID-19 pandemic on sleep in Chinese and Italian populations. So our objectives were to assess the impact of this pandemic and the lockdown on sleep in the general population. We wanted to compare specific groups of, for instance, those with suspected COVID-19 versus those without it. And we included also other subgroups of, for example, participants needing to self-isolate or key workers. We were also particularly interested in exploring associations with a reported impact on mental health during the lockdown. And so for these, we developed an online survey with the British Sleep Society, and this was widely disseminated. The link of it was disseminated via the members of the BSS, UK-based Sleep Center and patient charities. And it was available from the 12th of May to the 2nd of June. So it was available for 3 weeks. Eligible participants were people of 18 years old or above that. and of course, living through the COVID-19 pandemic and under national lockdown regulations. In this survey, we included demographic data, including things like the fact of working, being a key worker or not, of having needed to shield or having a disability. We included factors related to the COVID-19 pandemic and lockdown, things like having had or suspected to have had the COVID-19 infection, having ongoing symptoms, needing to self-isolate, an impact on mental health, whether there was an increased alcohol intake, and what was the general health rating. And we also included sleep characteristics, mainly things like whether participants were feeling refreshed or not, were they sleeping enough, the actual sleep duration that they were reporting, whether there was a change in their sleep pattern, if there was fatigue or sleepiness, if there were concerns about sleep, if there was a sleep medication used in the lockdown. And we also included a long list of sleep symptoms or sleep issues that we then, for the analysis, grouped into 6 sleep symptom categories. And these were insomnia, daytime symptoms, abnormal behaviors, sleep disorder breathing, restless legs, and sleep phase disturbances. In the statistical analysis, we included group comparisons based on categories such as the ones I mentioned earlier, having suspected COVID-19, self-isolation, key worker, impact on mental health. We did regression analysis, including outcome variables such as whether there was a change in sleep pattern, and including the 6 sleep symptom categories. And we assessed whether there were any associations of these with demographic or pandemic related factors. When there were significant associations, we performed further logistic regression modeling. And so we had a total of 843 respondents, and these were mostly female, middle-aged, predominantly white, and overweight to obese. Around 20% of them had suspected COVID-19. Over a third had to self-isolate. Over half of them, 65%, reported that the lockdown had had an impact on their mental health. 35% were key workers, and over a quarter of them reported drinking more alcohol during the pandemic. In regards to the impact on the sleep, less than half of the participants felt refreshed from sleep or felt that they were satisfied with their current sleep quantity. Almost 70% noticed a change in the sleep pattern during the pandemic. 46% felt sleepier than before the lockdown. Around 31% of the participants reported short sleep times, were sleep restricted with less than 6 hours of sleep. And these were older, had a higher BMI, were more likely to report shielding and disability, were more likely to report as well an impact on their mental health and sleep medication used in the lockdown. When taking into account the specific sleep symptoms or issues included in the survey, the most commonly reported were having a disrupted sleep, falling asleep unintentionally, difficulties falling or staying asleep, and going to bed later. A multiple logistic regression showed that a reported change in sleep pattern during the lockdown was associated to factors like younger age, female gender, having ongoing COVID-19 symptoms, reporting an impact on mental health, having a worse general health rating, and sleep medication use in the pandemic. The regression analysis to look at the associations between the 6 sleep symptom categories and demographic or pandemic-related factors showed that the presence of insomnia seemed significantly associated with sleep medication use, an impact on mental health, and having ongoing COVID-19 symptoms. The presence of daytime symptoms was associated with sleep medication use and an impact on mental health. Reported abnormal behaviors in sleep was associated with an impact on mental health and disability, sleep disorder breathing symptoms with ongoing COVID-19 symptoms and an impact on mental health. The presence of restless legs was associated with ongoing COVID-19 symptoms, mental health issues, and disability. And the reported presence of sleep phase disturbances was associated with sleep medication used during the lockdown, a reported impact on mental health, and increased alcohol intake. So overall, it seems that the main factors significantly associated with the presence of different sleep symptoms were a reported impact on mental health, sleep medication use, and ongoing COVID-19 symptoms. Participants with suspected COVID-19 reported significantly more nightmares and abnormal sleep rhythms. Those who self-isolated reported more insomnia, daytime symptoms, abnormal behaviors, and restless legs. Surprisingly, key workers did not report more sleep disturbances than non-key workers, and actually the presence of some sleep or daytime issues such as gasping for breath or daytime napping or getting up later were significantly lower in key workers versus non-key workers. In regards to the impact on mental health, as I previously mentioned, this was reported by just over 65% of respondents. The presence of mental health impact was actually a factor that predicted the presence of change in sleep pattern. And in a further analysis to investigate the associations between an impact on mental health and sleep symptoms, this mental health impact was predicted by the presence of issues like difficulties falling asleep, sleep disruption, excessive sleepiness, falling asleep unintentionally, and having nightmares, and was also significantly associated with other factors like having an increased alcohol intake in the lockdown and sleep medication use. So as a summary of our main findings, we can say that impact on sleep overall seemed significant. The majority of our respondents reported a change in their sleep pattern, and this seemed associated with a younger age, being female, having ongoing COVID-19 symptoms, reporting an impact on mental health, sleep medication use in the pandemic, and worse general health rating. Over half of our participants were unsatisfied with the current sleep quantity or quality, and almost half of them were sleepier than prior to the lockdown. Almost a third of the respondents reported sleeping less than 6 hours, and these seem to be older, have a higher BMI, be more vulnerable, or report more disability, and report more frequently an impact on mental health. The sleep issues or symptoms more frequently reported seemed dozing off unintentionally, disrupted sleep, difficulties falling or staying asleep, and later bedtimes. And so these results overall seemed somewhat expected, as we know that prolonged lockdowns are associated with insufficient sunlight, less physical activity, dietary changes, increased screen time. And so all these factors, as well as other things like, for example, work, family, financial issues, overall the change of our routines, we know that they may have a negative effect on sleep. Our results are similar to those presented by other countries, such as Italy, China, another survey that was done also in the UK, and other work done in the US, where disturbed sleep, later bedtimes, so sleeping fewer hours, and worse sleep quality have all been mentioned as issues during this pandemic. In our study, over a quarter of participants reported having an increased alcohol intake during the lockdown. This factor and sleep medication use during the pandemic were actually associated with an impact on mental health. And these data are especially relevant given that the associations that there may be between increased alcohol intake and worse scores of depression, anxiety, and stress. The data that we got is consistent with what was reported by Alcohol Change UK. Despite decreased social gathering, it seems that 20% of the population are drinking more frequently in the lockdown, and not only because of the relationship with mental health, but also because of the impact on sleep itself. This should not be overlooked. We know that alcohol may disrupt the sleep architecture, can exacerbate the sleep pathologies like, for example, OSA, and can worsen daytime sleepiness. In regards to the subgroups that we analyzed, we found that those with suspected COVID-19 reported more frequently nightmares and abnormal sleep rhythms. And more specifically, those with ongoing COVID-19 symptoms seem to have significantly more presence of a sleep disorder breathing symptoms, insomnia, and restless legs. And these findings are relevant because, as you know, a range of neurological symptoms have been reported in patients with COVID-19. And one may hypothesize whether there is an involvement of areas in the central nervous system that control the sleep and wakefulness that may be affected and partly responsible for some of these symptoms. And not only that, more specifically talking about a sleep disorder breathing, we now know that many of the risk factors and comorbidities for OSA are associated with poor COVID-19 outcomes, and as well we know that post-COVID lung changes may increase the risk to develop OSA. So all this information, together with the fact that there may be a high percentage of OSA patients that have not been diagnosed yet, and given that the pandemic is ongoing, it is relevant to remember this association between the two. In our study, self-isolators reported more symptoms of insomnia, more daytime symptoms, more abnormal behaviors in sleep, and symptoms of restless legs. However, in contrast to what has been shown in many other studies during the pandemic, queue workers reported fewer sleep symptoms in our survey. From the mental health perspective, over half of our respondents mentioned that they felt that the lockdown, the pandemic, had an impact on their mental health. This actually seemed a predictive factor of a change in sleep patterns, and a reported of impact on mental health was predicted by the presence of some sleep difficulties, like problems to fall asleep, sleep disruption, daytime sleepiness, and the presence of nightmares. And this is consistent with further evidence showing that worsened insomnia and poor sleep quality was significantly associated with several mental health issues. And there were, of course, some limitations to our study, and the first one that we thought was important to mention is that there's probably a selection bias. Those respondents, participants suffering from sleep issues were probably more likely to actually contribute to the study and complete the survey. The survey was widely distributed, and this could have included participants living in different countries and with different levels of lockdown measures. The self-reported status of suspected COVID-19 was always subjective. We did not, of course, require positive formal testing, and we did not ask about this. There was no objective assessment of a sleep disorder, so there were no formal sleep tests undertaken. And unfortunately, there was a limited diversity in the respondents' ethnicity. So we were not able really to assess the impact of the pandemic on sleep in ethnic minorities. And so overall, to conclude, we believe that it seems that there is a significant impact of the pandemic on sleep. We have found that the majority of the population has experienced sleep problems during this time. Particularly a change in sleep patterns was reported by almost 70% of our respondents. And then there was also a report of a specific sleep issues such as daytime sleepiness, difficulties falling or staying asleep, and later bedtimes. Problems with sleep seemed closely related with a mental health impact, self-isolation, and COVID-19 symptoms, either as having had suspected COVID-19 or reporting ongoing symptoms of COVID-19. Increased alcohol intake in the pandemic should not be overlooked. As I mentioned earlier, it's probably related to some of the mental health disturbances that are reported, but also can have an impact and can be linked to the sleep issues that we are seeing. And overall, these findings, which are also supported by other works done around the world in the pandemic, should warn us of the need to address sleep issues early in these circumstances and try to minimize the impact that the current situation may have on mental health and well-being. And that's all. Thank you for your attention, and thanks to the colleagues at GUISE and at the British Sleep Society for their work to get this study done.
Thank you very much, Laura, and thanks for the presentation of something that has somewhat affected us all over the last year, one way or the other, yeah? I mean, when we did that work, it was quite interesting to see that certain characters actually reported better sleep, but in large, if you look population-wide, this was having a massive impact, such a change of life. Often associated maybe with worries, financial worries, job worries, health worries, anxiety. Yeah. So if I look at this, just to start off the questions, pre-medication might make an impact. Alcohol use might have an impact. Mental health issues causing disrupted sleep, causing difficulties falling asleep, excessive daytime sleepiness, etc. Do you think our health services in terms of support for mental health issues are currently up to speed to cope with this? Or what would be your takeaway message from your experience? Maybe how can we improve looking after such issues as what you've just described?
Yeah, so I think that's a really good question. I think that the feeling of all of us in these circumstances is that we were not really prepared for this situation, generally speaking, and of course in every single department of every single hospital they must have felt that way, because we didn't see this coming, and we had never experienced anything similar. I think that we can learn from this data and from our own experience working at the Sleep Center, that we probably need to give a bit more focus on the relationship between sleep and mental health, And of course, in our case, for example, we have a sleep psychologist, psychiatrist also involved in the service, which are of great help. But I suppose that this should be more widely available when we are taking care of sleep disturbances, and especially in these very unusual circumstances, it's come up as a very relevant thing to actually be able to provide. Of course, there is the limitation of how to provide that when you are in the middle of a lockdown and of a pandemic. And again, I think we are all learning from what's happened, and we are trying to get all these virtual appointments and clinics up and running so that the support is available for the patients when they need it.
Yeah, thank you. A few questions coming in. Julian Baker asks, does anyone know the answer? What people would say if they were asked how they sleep under normal, not lockdown conditions. That's of course a tricky thing, and we had pre-post comparison, which was self-reported, but do you have any insights on that? How many % of patients or the general population would typically report difficulties at any given time? I mean, I know that there are numbers in space talking about 10% suffering with insomnia at any given time, but I don't know how accurate these numbers are. Do you have any comment on that?
So I think that's the issue, that we don't have pre and post data, and so it's a bit difficult to actually know if we are facing 100% a worsening of a previous situation. I think that when we're talking about things like a sleep restriction, insomnia, we know that it's always going to be prevalent in the general population, regardless of the circumstances around. So we know that maybe the pandemic is not the key factor in that sense. But I think that the key thing in our survey is that quite a lot of the questions were asked as a change on sleep pattern, or having these compared to before the lockdown, being sleepier compared to before the lockdown. So we kind of like tried to do a comparison by formulating the questions in that way. So I think that it's probably, there are some of these issues that are prevalent anyway, but I think that the responses from this survey also show that there has been a change compared to pre-pandemic and pre-lockdown.
Thank you. And maybe just a short speculative question from Adrian Williams asking, does the shift in sleep timing reflect inherent chronobiology, maybe due to lack of sun exposure or so, physical activity, or just a change related to sleep hygiene and light exposure? So what's your view as to what could be the underlying cause for all these difficulties that we've seen here?
I think it's probably a combination. So we know that sleep hygiene has changed because of the circumstances. Our routines have greatly changed during the lockdown. So that is for sure playing a very, very significant role. But equally, the fact that you're not exposed to as much natural light as you should, or you are using screens throughout the day and until late in the evening, that must be contributing as well. So I think that it's probably a bit of both, and yeah, it would be quite tricky to actually blame just one for it.
Yeah, I mean, we might learn more about it now in the winter time with the second wave, unfortunately, but we will all stay vigilant to understand the issues more so. Laura, thank you very much. Yeah, thanks for presenting these data from the British Sleep Society. And so we move on, and it gives me a great pleasure to introduce the next speaker, Dieter Riemann from the University of Freiburg. Dieter, not that he needs a lot of introduction, he's the founder of the European Insomnia Network. He's the treasurer of the European Sleep Research Society. He's the editor-in-chief of the Journal of Sleep Research, and he has got a talk prepared, Insomnia and Mental Health, the Role of Hyperarousal. Dieter, thank you for joining us today. Next time we meet, hopefully in person again in London or in Freiburg. Dieter, over to you.
Well, thanks for the very kind introduction, Jörg. It really is a pleasure to be part of this enterprise, and I would have preferred going to London, but we all know how it is. So I'll give you a virtual presentation today, and I'm talking, actually this nicely ties in to the previous talk. I will talk about insomnia and mental health, and with an emphasis on hyperarousal. I don't have any conflicts of interest. And actually, I have two learning objectives. This would be to understand why sleep is important for mental health and understand why insomnia treatment could be a preventive strategy for mental health. This is my agenda. There'll be 5 points listed here. I'll give you a brief overview of the history of psychiatric sleep research. I'll talk more generally about REM sleep and the function of sleep, then come back to arousal, briefly give you some data from a meta-analysis of sleep in mental disorders, and end up, what is the clinical relevance of all of this? What's the message for the clinician? Actually, this rather sinister looking gentleman is Emil Kraepelin, eminent German psychiatrist in the 19th and 20th century, and one of the fathers of modern psychiatry. And he noted, and I translate that for you, this is German text here, that especially depression is coupled with insomnia, problems to fall asleep, problems to maintain sleep, early morning awakening, and associated daytime consequences like fatigue. And this is an association which was already known in Greek antique times and noted by Greek healers and physicians. If we go a bit further in time, now we switch to 1970. These are some data from an American hospital, 1,500 patients who were hospitalized for depression. And what we have here is the Singer symptoms. So we see that a depressed mood is present in 100% of patients. Well, that's logical in depressed patients, but also insomnia. Actually, that was for a long time, this has influenced psychiatric thinking, that actually to have insomnia was equivalent with being depressed. And actually, I want to show you in my talk that it can be also the other way around. Not only insomnia is a symptom of depression, but also insomnia can be a risk factor for depression. And an important point was the introduction of polysomnography to psychiatric sleep research. These are data from the 70s. You all know the normal sleep profile up here, the regular cycling of non-REM sleep. And down here, you have an unmedicated, severely depressed patient. And you see the sleep continuity disturbance, the early morning awakening. You see here the reduction of slow wave sleep. And what was intriguing was the early onset of REM sleep. This is like in narcolepsy. This is a sleep onset REM period. And initially, this was thought to be a biological marker for especially endogenous melancholic depression. And at that time, and still, psychiatry is looking for biological markers for its diseases. And that was one of the first chances to find something. And what also was very interesting is that we know that 90% of antidepressants we have on the market do suppress REM sleep. They correct this imbalance. And what made this finding so intriguing or so important was the fact that it could be nicely linked to models coming from basic sleep research. For example, this is the regulation of non-REM and REM sleep. And it says that non-REM REM sleep is governed through cell groups in the brainstem, aminergic cells active during non-REM sleep, cholinergic cells. And it was easy to postulate then that this early onset of REM sleep might be due to an imbalance between these two neurotransmitter systems, dysfunction of the aminergic system and overactivity of the cholinergic system. So actually, this all led to the idea that especially changes in REM sleep might offer us a window into the brain. And that was in pre-neuroimaging time. And another finding, which another theory, the findings in depression were linked with what the two-process model of Bowlby. And actually, it was said here that we have a deficiency of process S, and is reflected in less slow wave sleep, and sleep deprivation will increase process S and thereby have an antidepressant effect, which is known. So there was a very fascinating time, 1780s and the 80s, but there were disappointments in the 90s then, because it was shown that these findings in depression of REM sleep are not so specific as were they thought. And we had the development of neuroimaging, which is much easier to apply. Let's say 30 minutes MRI is easier to be done than, let's say, 2 or 3 polysomnographic studies over 8 hours each. So there was a kind of loss of interest in these findings, but I show you there's a revival now. Now let me have a few words about REM sleep and the function of sleep, because we need to talk about that in order to understand the importance of these sleep changes in mental disorders. This is taken from the original paper by Azurinsky and Kleitman from the Science paper from 1953. And I'd like to show you here a short film, a young lady, a medical doctor, and actually we filmed her during REM sleep, and you will see the eye movements, but also we show you a brief sequence what happens after lights out, and this seems to be something very typical nowadays for young people. So this is still before sleep. Actually, in this study, people were allowed to have their phones with them, and almost everybody used a mobile phone prior to trying to sleep. And here you have the rapid eye movements. So we have the rapid eye movements in REM sleep. We have the low voltage EEG, which corresponds with an increased or with a hyperactivity of the brain in REM sleep. This is the first PET study, and what we see here is increased activity in the pons, in the amygdala, emotion regulation, in the thalamus, and in the cortex. So sleep, and we all know that from the sleep community, is not just a and these findings have led Matt Walker to speculate about the role of REM sleep for emotional processing, for emotional brain function. What is shown here is a kind of desensitization of emotion over the successive REM periods of a night, meaning that emotions and memories are reprocessed, and as there is no noradrenergic input during REM sleep, normally the emotions are processed, and in the morning we still remember things, but the emotional quality has been altered, or at least we have been able to deal with the emotions either negative or positively. And that's a very kind of fascinating hypothesis, because it has lots of implications for if there are REM sleep disturbances. And then we have the muscle atonia in REM sleep, which is something very fascinating because it keeps us from acting out. If we talk about more general functions of sleep, definitely energy saving plays a role, metabolic restoration, brain maturation, especially during during infancy, but also information processing, memory consolidation. This is taken from 2 papers, and especially from Dickelman and Born. This shows how this is thought to function, that during sleep, especially during slow wave sleep, information or memories are transferred from the hippocampus to the cortex, to the neocortex. So we have already 2 functions of sleep: emotion processing, information processing. Then we have another function put forward by Tononi and Girelli, the synaptic homeostatic, saying downscaling happens during sleep, especially in slow wave sleep, which is very important not to suffer from some kind of load of information. And last but not least, a few years ago, Nedergaard in Rochester came up with the hypothesis that sleep helps us to remove potentially neurotoxic waste products, especially beta amyloid, from the brain. So we have lots of fascinating hypotheses, and they are not mutually exclusive, I think, or I'm strongly in favor assuming several functions for sleep. REM sleep, emotion processing, slow wave sleep, memory consolidation, synaptic downscaling, and maybe the garbage truck. So this is the premise under we work here and in my department, that sleep and mental health very closely related, and that disturbances of sleep, either be it sleep apnea, be it restless legs, be it insomnia, has a strong impact on the brain and on mental health in a negative way. On the other hand, providing or having good sleep, having sufficient sleep, improving sleep might also be a very general measure to improve our brain and mental health. A few words about insomnia and hyperarousal, something which I've been interested in for a very long time. Here are the most recent insomnia disorder diagnostic criteria. This is DSM-5, the psychiatric system, but we find the same, more or less the same criteria in ICSD-3. And it's highly probable that also ICD-11 will take up these criteria. So here we have, for insomnia disorder, we have a sleep complaint, in difficulty initiating sleep, maintaining sleep, early morning awakening, and we have to have associated clinically significant distress or impairment during the day on several levels of functioning, social, occupational, educational, whatsoever. And we have some frequency criteria, 3 nights per week, 3 months, and we have some exclusion criteria. There mustn't be any other sleep disorder explaining the insomnia better, or there mustn't be a substance abuse, there mustn't be another somatic or mental disorder explaining the insomnia better. But DSM-5 was very important because the old distinction in primary and secondary insomnia was given up, which really, in a way, blocked insomnia research and insomnia awareness, because it said, okay, in most cases, insomnia, it's just a symptom. And the insomnia will go away when you treat the underlying disorder successfully. And we've seen in the past 20, 30 years that this is frequently not the case, especially in the mental health arena. What about prevalence? We've talked about that. Here is a prevalence slide, different European countries. This is from the European Insomnia Guideline. And we took studies who had, according to certain quality criteria, and interestingly, for example, we have England with, this is insomnia diagnosis. This is not symptoms, like almost 6%, Germany, France, almost 20%. So you see, there is a huge variation around European countries. I would say for Germany, the data at present, and there have been 2 very excellent epidemiological studies, suggests that insomnia disorder afflicts approximately 9 to 10% of the adult population. So it's a frequent condition, yeah, and it's more, it increases with age, and it's more prevalent in women than in men. The hyperarousal idea is not very new. It's quite old. This goes back. This is from the British Medical Journal from 1877. And here it talks about differential diagnosis. It says there's senile insomnia, there's toxic insomnia, and there's psychical insomnia. And they talk about the toxic causes, which is alcohol. We heard about the tea, tobacco. You can treat it by remove the cause, proper sleep hygiene. Don't smoke, don't drink, sleep gets better. On a psychological or psychical level, here the author says, the insomnia arises from continued and excessive mental strain, grief, anxiety, worry. This would be the hyperarousal. And at that time, 150 years ago, actually bromides were used to treat it. And I would strongly not advise to use bromides anymore, because the threshold between therapeutic and lethal dose is very small. And what they say here as well, and I would underwrite the sentence to a certain limit. If the insomnia be serious, it must be stopped at once. I fully agree with that. By hypnotics, preferably by opium. I wouldn't agree with that. And we all know that till the prohibition of opium, that probably at least those patients who could afford it, they had two problems after a few weeks. They not only had insomnia, but they also had an opioid addiction. Let's come to more modern concepts. This is the Spielman model, the 3P model, saying actually almost everybody has insomnia for a limited time, 1 or 2 days, a month, maybe, or every 3 months. So this is a common human experience. But why do only 10% develop chronic insomnia? And Spearman said there must be something premorbid here. And there is evidence out there now that genetic factors play a role, from family studies, from GWAS studies. So definitely genes explain why some people develop chronic insomnia. And we assume that like 30 to 40% of the variants is explained by genetic influences. We have precipitating factors, for example, the COVID-19 pandemic, and we have, that's probably the most important point about perpetuating factors, which Spielman identified as maladaptive behaviors, like, for example, prolonged times in bed, alcohol consumption, etc. We come to that later on. And because these can be changed, the perpetuating factors, if they are behavioral, and they are the target of cognitive behavioral therapy. Another model was suggested by Charles Morin almost 30 years ago, Canadian insomnia researcher. He also stresses the arousal, which is present in many insomniacs, the dysfunctional cognitions, mood disturbances, irritability, fatigue, and so on. Here is a brief video from a documentary film called Wide Awake, and the director is Alan Bernina, and he made this film because he himself suffers from chronic insomnia, and you will see him what he experienced during the night. I think you get the picture. And I assume that probably most of us have experienced this maybe once a year, once a month, not being able to shut off and ruminating the whole night because something important had happened or something important is going to happen the next day and you start thinking about it. But imagine going through this every night. And it's really, it can be kind of torture if you detect then that you're unable to shut off. So next, I go ahead with two videos, and this is just the behavioral level of a good sleeper and a poor sleeper, an insomniac patient, and this is 8 hours in 30 seconds. Yeah, and I think I don't have to tell you who is who, and we all know that good sleepers also turn and move during their sleep, but it's quite clear that there's a much higher level of motor activity in our insomniac subject here, which you wouldn't see if you look at it over 8 hours, but you see it if you compress the whole thing to 30 seconds. Okay, but what is wrong with polysomnography in insomnia? We've done a meta-analysis, and all the variables here in red indicate significant differences between good sleepers and insomnia. There is a reduction in sleep efficiency, there's prolonged sleep latency, there's reduced total sleep time, there's less slow wave sleep, less REM sleep, more wake time, but not surprisingly, and we had known that before, the absence The difference between good sleepers and insomnia in total sleep time is something like 25 to 30 minutes. And that is the so-called paradoxically insomnia or sleep misperception, which is also known now for 30 to 40 years. If we look at the subjective side, we get like 2 or 3 hour differences on questionnaires between insomnia and good sleepers. If we look at polysomnography, we get significant differences, but they are much smaller. And that has led to a kind of mistrust also with respect to insomnia. We're not taking the complaint really serious, but we think that probably an explanation for this discrepancy is that it's not the macrostructure which is really dramatically altered, but it's the microstructure. And here we have a good sleeper again, here we have an insomniac patient, and you see on average sleep efficiency is maybe a few % less than a good sleeper. But what is characterizing insomnia sleep is the fragmentation. Many brief arousals, short wake periods, especially during REM sleep. And up here we have the micro arousals. And here on the right side, we have the difference in frequency bands. We have increased frequencies, especially in the fast range, in the sigma and beta range. And we think, many others assume, that these changes in the microstructure explain why many people with insomnia experience their sleep so unrestful, sometimes have the feeling that they have been ruminating whole night, because there is a superimposition of fast waves and there are these many brief microarousals. This nicely ties into this overall idea of hyperarousal, saying we can measure that in the brain with the fast frequencies. We have changes in the body, increased metabolic rate, increased body temperature, heart rate is altered, not dramatically, but significantly. Also, if we look at the brain, and this is a summary from us 5 years ago, we think most of the neuroimaging studies clearly are in favor of saying that in insomniac sleep, we have corticolimbic overactivity interfering with sleep promoting structures. So there's a kind of disbalance between the wake system and the sleep system. Here shown the ARAS, the activating system, and we have a sleep generating system. This is an oversimplification. We all know it's much more complicated, many brain centers involved. And what we suggest then here is that insomniac sleep is some kind of hybrid sleep. There is no clear-cut difference between the sleep and the wake state in insomnia like it is in a good sleeper. The wake promoting areas are blocked, the sleep promoting areas are active. In insomnia, there are very frequent interactions between these systems, leading to this hybrid sleep, and maybe some parts of the brain are more awake than they should be. Let's go back to mental disorders. I just show you brief results from one meta-analysis we performed and published a few years ago. And what you can see here is, if we look at sleep continuity, and sleep continuity reflects sleep onset latency, sleep maintenance, early morning awakening, we see that almost all mental disorders changes in sleep continuity, which suggests that like insomnia is a transdiagnostic marker or mechanism of mental disorders, whereas like REM sleep changes are more specific for depression and, for example, borderline or schizophrenia, but not for all mental disorders. And this leads us to the question then, what is the clinical relevance of all of these bidirectional relationships between sleep, insomnia, and mental health? This is another meta-analysis. I have to bore you with that, published by Elisabeth Hertenstern from my group just 1 year ago, and look for the depression and anxiety. These are longitudinal studies with at least 2 measurement points looking at insomnia and insomnia as a diagnosis and mental disorders as a diagnosis, and with a baseline measurement. And what you can see here is that insomnia is a risk factor for depression and anxiety disorders. We don't have so much work for pain and alcohol and psychotic disorders, but there's a clear-cut signal here. 2.8 increase for depression, 3.2 for anxiety disorders, if you have insomnia alone. So not only are almost all mental disorders coupled with insomnia, insomniac symptoms. On the other hand, insomnia alone as a disorder also has increased risks to develop mental disorders. And we've wrote a lot about that and speculated about that, how that works. The basic idea is to suggest that insomnia could be like a gateway. If you have the specific genetic vulnerability or makeup and you develop chronic insomnia, this might in the long run for like depression, anxiety. So the question is, could insomnia treatment be a preventive strategy for mental disorders? There is one study already out there from Australia, an online study, which showed that treatment with cognitive behavioral treatment can reduce depressive symptoms compared to a placebo treatment, especially also in the long run. So there's good positive evidence out there, but we need more studies to prove that. What about and I'm coming to the end of my talk now, what about current guidelines? We have one from the ACP, the American College of Physicians, we have one from the ASM, we have one from Germany, we have one from the UK. I don't have it yet, we have the European one. And what is suggested here, and you can read that up, is a proper diagnosis, including medical anamnesis, looking at psychology, psychiatry, sleep, and in some cases, and also polysomnography in some cases of insomnia. Now, what the conclusion is that cognitive behavioral treatment for insomnia is first-line treatment, and a pharmacological intervention can be offered if CBTI is not effective or available, and that's the crux. And we are working, really, the Insomnia Network and many others, we are working strongly now on establishing CBTI teaching to health professionals in order to increase the number of professionals out there who can work with CBTI. And what is probably a very important point here is a stepped care approach, as suggested by Colin Espy, who is now in Oxford, saying probably as a patient, you may start by self-administering CBTI with a book or via the internet. And there's now strong evidence that internet-based CBTI can be effective. Then you may go to kind of a low level treatment like community nurse, or then you may move up through the general practice up to the specialist. Not given that we have 10% insomniacs in the population, it's quite clear that we will not cope with these people by individual treatment by psychologists or neurologists or psychiatrists, but we need other forms, we need group formats, we need internet-based formats. And we're also presently working on a large-scale study in Germany, in my department, exactly testing this model, how it fits with the needs of people with insomnia. Thank you very much for your attention.
Thank you very much, Dieter, and apologies to the audience who complained about some sound issues. It was periodically phasing in and out. This must have been down to the internet connection. Apologies. But Dieter, what a great talk, and very well fitting into the previous topic with
Brilliant.
Mental health, anxiety, depression. Just to pick up maybe with the first question before handing over to Esther, on what you said on the last slide with the pyramid, the delivery of healthcare. So what is currently in Germany, for example, available already over the internet remotely to support patients with insomnia? Here in the UK, we are very interested in remote telemedicine nowadays, and there are different options available, but of course, to cope with the demand, it's a difficulty. What's available on the continent?
Yeah, okay, first of all, you all probably are aware that Sleepio is available in the UK. Colin Espy is behind that, and there have been very good data published on it. The thing is, we are working with a system which is called Get Sleep. We're doing this in close collaboration with health insurance. So Barmer Ersatzkasse, which is, I think, the biggest health insurance company in Germany is working with us. And actually at present, it's only available if you take part in the study we're working on. This will be a study with 4,000 people. But if the study is successful, it will be available to everybody, and probably health insurance, you'll get it through your health insurance. So your doctor gives you a prescription, or maybe a nurse, for the program, and you get a code then, and you go on the internet and you get access to the program, and the people or the company who developed the program will be paid through health insurance. I think that's how it has to be. There are at present the two main systems I know are from English-speaking countries. The one is Sleepio in the UK, and the other one is Shutai, which comes from the US, from Ritterband and Maureen. But I know there are programs in Swedish, there are programs in Dutch. So this is, and especially considering Corona, this is exploding.
Yeah.
But we need quality control for that.
No, you're absolutely right. And of course, remote virtual consultations will be there to stay to some degree, even if the virus disappears. Dieter, thank you very much. Esther, there were some other questions.
Yes, thank you very much for sharing your knowledge and experience in insomnia. I think we all can learn a lot from you, because insomnia is probably also present in our patients, or a different relevant aspect for them, patients with other sleep disorders that we see. And you have nicely shown the multidimensional impact of sleep and insomnia on mental health and the reverse relationship. And in terms of multidimensionality, could you maybe say something about the diagnostic or armamentarium we have to assess these aspects, and what we can also use to target therapy or interventions?
I think the diagnostic situation at present, at least as I know from Germany, is not satisfactory, because we know well in German general practice, it's 5 to 7 minutes each patient gets, and well, you can't ask a lot of questions there, but we think this is not acceptable. And you need to build up a certain trust with the insomniac patients, because they won't talk about their mental health issues if you don't have built up some trust. We need to take it seriously also on a somatic level. We need to have a medical history. We might need to run blood tests, thyroid function, etc. Because many people think, insomnia, it's a psycho thing, psychologically, so I don't have to do any somatic diagnostic. I think this is wrong. We might do even an ECG in some patients, really depending on how the patient is presenting. We need to have a proper look at the psychological, psychiatric side. And there are questionnaires. I would suggest always use the PISCI and use a sleep diary. Use a 2-week sleep diary. We say our patients who make an appointment with us, they get mail and they get a sleep diary, and we ask them to fill this out before they come to our offices. And so we have, and this is a very cheap kind of diagnosis. It costs you 10, I don't know, one page of paper, it's 10 cents. And I think you can expect, if somebody has chronic insomnia, that they fill out a sleep diary. That's not too much. And I have experienced very frequently that patients say, it has been a relief to see that my insomnia is taken serious. And they are not complaining about the questionnaires, but they're saying, somebody takes me serious, because they're sending me so many stuff. And then in my consultation, I go through the questionnaires with the patients and then get the additional information. And we also do polysomnography if we suspect sleep apnea, if we suspect cases of occult restless legs, periodic leg movements. And also if patients say, I'm not sleeping at all or something, it can be very helpful. And I know in most cases, you'll be able to show that there is sleep. And there is even 5 or 6 hours of sleep. But really, there should be, at least for a first consultation of chronic insomnia, there should be a very comprehensive intake evaluation.
Yes, thank you very much. There is a lot of interest when we think on hyperarousal, on drug therapy, or how we could influence that.
Yeah, there is the hyperarousal concept might offer a lot of new ideas. Not only think about benzodiazepines, I mean, they're also dampening the hyperarousal or the BZRA or many psychopharmacologic agents, but also drugs, antihypertensives might be of high interest there because so they also block or influence the noradrenergic system. And I've yet have to see any, well, there may be some small scale studies. And actually we were very interested in that and doing studies in that. And then we looked up patent registries and we realized that somebody has a patent on hyperarousal and using antihypertensive drugs. So somehow this avenue is blocked and I'm still waiting that something is coming out of this. Somebody must be working on this, some company.
So a lot to do in this field in terms of research as well. So thank you very much. And then I would like to give the word back to Jörg, who has kindly brought us all together and organized this meeting. And he will tell us about the special issue.
Great, thank you very much. And thanks, Dieter, for this lovely talk. So let me just go to my screen and share. And whilst I do this, also mention that besides SleepView, the Sleep Station was mentioned here in the chat, is available in the UK. So of course, this is something to consider, that there are different providers that are available on the NHS. So now let me just see, Dieter, if you could stop sharing your screen somehow, or do I need to override this? I can't currently share my screen. Apologies. Let's try again. Danny, I cannot get up my PowerPoint. Would you be able to do that on my behalf, please? Sorry for that short delay. Danny? Technical support. Let's try to open everything again and then try to share. Just a moment. Aha, there it comes up. Good, so that will be the last talk. Apologies that we're slightly behind the time now, but in the original clinical update sleep, we had always dedicated
So really sorry for the technical problems. I hope they can be solved. Jörg seems to have lost the internet connection. Sorry for that. So he has prepared a special issue that has been published yesterday in the Journal of Thoracic Disease, and it covers a broad spectrum of topics, also all the talks that we have heard today. And there are also other original data and reviews. And now we have Jörg back, I see. Jörg, could you unmute yourself?
I'm sorry,
Yes,
I must have dropped out.
Welcome back.
Apologies. These are the downsides of telemedicine, or in this case, educational delivery. Apologies. So you can hopefully still see the screen that is shared. Can you see that? Great. So we've got here the table of content with some original manuscripts and some reviews. And I, in the remaining minutes, want to talk you through some of the papers. So we've got here a paper where we looked into the different classification that the American Academy of Sleep Medicine brought out to score apneas and hypopneas There were originally, of course, the Rechtschaffen classification, and then in 2007 this was refined with certain criteria defining hypopneas. And then it was refined again in 2012, and it became more sensitive. So the hypopnea classification in particular changed their definition from more than 30% reduction in flow plus an associated more than 4% desaturation. They changed this in 2012 to a more than 3% desaturation. And we looked actually in the cohort of patients with COPD OSA overlap syndrome into how this would change the kind of numbers of patients that we would identify as to have COPD OSA overlap syndrome. And if you look at the results here, again, open access all on the JTD, then the change in classification made a difference in the number scored with hypopneas by plus 48%. So a very substantial increase in hypopneas that would have been scored. But what is interesting, if you think about man-made definitions, actually 92% of these additionally scored hypopneas did go hand in hand with an associated arousal. So did we previously underscore? Do we now overscore? This is certainly a controversial area, but it's an interesting observation. And just to keep this in mind, because as you grow into your experience in sleep medicine, you want to understand the methodology, you want to understand the classification that you're using when scoring to understand actually what you're talking about and whether or not certain patients are more or less affected by what you try to characterize with a pure clear-cut number, the apnea-hypopnea index. So then we've shown actually that in the Lane Fox unit service, a large Center for Home Mechanical Ventilation, we could increase long-term adherence as defined by those patients who drop out due to non-usage, divided by the number of patients set up in the same year, new on non-invasive ventilation. And we've shown that actually over the 10-year course that the service was reviewed, we could reduce this kind of non-adherence number by establishing educational content, including the technicians in regular upskilling of the patients, and having specific CPAP and NIV non-adherence clinics to reduce this number significantly, which is important because, of course, if you leave the equipment, CPAP or NIV with the patient, the costs are running, but if the patients don't use it, they don't get a benefit from it. So this is highly significant and important. Now from Esther's group, some insights on a cross-section analysis of the sleep heart health study, where they looked into heart rate variability as a marker for sympathovagal imbalance. And the interesting bit was here that the sleep fragmentation stood out as the one marker that went hand in hand with a sympathetic predominance in the signal. The total OSA severity or nocturnal hypoxemia did not necessarily contribute so much. So sleep fragmentation from that analysis seems to be the problem, increasing sympathetic tone. Here, a paper establishing some standard levels and scan areas of the upper airway using ultrasound in the context of stimulating with electrical current the upper airway dilator muscles to treat obstructive sleep apnea. Now, there's very little literature around standard planes in the upper airway using ultrasound, and here a couple of very nice pictures in the sagittal and coronal axis looking at the genioglossus muscle and the contraction that goes hand in hand with external electrical stimulation. So quite pleased to see this in the context of what our group does with electrical stimulation. We've got some insights here on the post-polio syndrome, which is also a large cohort of patients who come through our center because of the neuromuscular involvement and often associated sleep disorder breathing. Here, particularly Alexandra Curtis and Jung-Soo Lee, who have run for the last 17 years, dedicated a fantastic self-management course looking at patients with post-Pullis syndrome and teaching them and giving them individualized rehabilitation programs and therapy by the hand. And actually what this shows is that such a dedicated course can not only increase, of course, knowledge, but also symptoms and walking speed. And so in the context of another now unfortunately devastating viral pandemic, leaving many, many patients with what's called now either long COVID or post-COVID or however you want to call it, we will see more patients with neuromuscular problems with significant life disturbance and detrimental effects on their quality of life in the post-COVID scenario. So maybe something that we can learn from this. Laura has, of course, presented her data in a fantastic talk, and there's such a wealth of data, and there were so many questions that I tried to refer to this article. Please read it. Download it, it's open access. There's a lot of more background, and particularly the discussion section, I think, will give you more insight as well. So well done, Laura, and thanks again to the British Sleep Society for collaborating with us on this, because this is obviously a matter of the time. And then thanks to all the contributors who can't talk today, but hopefully will be part of the Clinical Update Sleep event in March. Plenty of reviews, so anyone interested in sleep will find something here, from liver disease and sleep, Pompe disease, sleep and stroke. Laura has written that piece as a review on pulmonary hypertension, COPD, non-invasive ventilation. Martino's group has written a review on blood pressure control and the cardiovascular prevention. There were a lot of questions around that. If we still find time, we might talk about this in a moment. And on telemedicine from the German group around Professor Schöbel and Teschler. So keep an eye out for this. If you think you want to read something related exclusively to sleep, then download this agenda. It's all live since yesterday. So, and this is really just to say thank you to the British Sleep Society, who also had planned the original day today with a symposium, but this will all now happen in March. One way or the other, we will bring it to you. So bear with us and bear with our technical difficulties. In case there will be sound issues, I apologize. So this is the Journal of Thoracic Disease. We've got 3 minutes left of the official time, but let's go back to the live chat show and see whether there are any further questions and answers to be given. Esther, I think you're on mute.
Sorry for that. I think a question that we often hear and that was asked by several members of the audience was, how do we translate the knowledge on blood pressure effects or potential cardiovascular prevention into treatment recommendations? And unfortunately, Martino has to work on the ward, so he cannot participate in the discussion. But Jörg, how do you handle this in everyday clinical practice? If you see people with cardiovascular burden and very high blood pressure that is not well controlled, but they are not symptomatic, and you see they have seriously bad.
Of course. I mean, this is everyday bread and butter for us, that we need to convince our patients to be compliant with the treatment, which they may not like. So there were already questions around how do you make this work for someone. Martino hinted in his talk that high pressures, avoidance of air leak, and of course perfect mask fitting and accurate pressurization, this will all help to create perfect circumstances for someone to succeed to use this in the long term. But then if you look into this, and even the randomized controlled trials that we have show that long-term adherence is limited. A quarter of the patients after 3 months struggle, and after 1 year, this might be 50% of the patients not using CPAP to the point that you would say they get a sufficient treatment effect. Now, after all that I've seen from Martino on the one hand and know about the phenotyping on the other, I would say it's always encouraging to know which patient group you should focus on. So if we know younger patients benefit, sleepy patients benefit more from CPAP in terms of blood pressure response, adherence is of course an issue, but also with the Andante collaboration, we will be more likely to predict other subgroups in future to say, well, look, you will actually have a much more likely response with your blood pressure to CPAP adherence. Then this will be one part of the equation. The other part of the equation is, of course, phenotyping, and those where we have tried everything with CPAP, we might need to consider other treatment options. There was a question from Barry Quinn around mandibular advancement devices. Esther, you answered this in the chat. So also other modalities than CPAP might have an effect, a beneficial effect on CPAP, on blood pressure control. Keep in mind, the cardiologists have taken this over the last 15 years into their international guidelines that treatment-resistant hypertension is the most common reason to be found by untreated sleep apnea. So treatment-resistant hypertension, red flag should go up in everyone's consultation with the patient, that there might be something to do around OSA control. It's important. It's an important matter, and if you really struggle with adherence with the patient, I also posted a link earlier on to a little study that we published in 2018 on framing. Because it depends on how you try to sell CPAP to the patient, and we tried at that time positive framing. So if you use the treatment, you will feel less sleepy, so a positive framing. But then we also compared this to negative framing. So if you do not use CPAP, you will be more sleepy than you should be, and so on. And so from that paper, all that I want to say, read it, it's Pengo in the Journal of Thoracic Disease at the last clinical update Sleep 2018, open access. All that I want to say with regards to that is, in the beginning, and we do know that early compliance translates well into later compliance. So early on, positive messages seem to be helpful. Later on, usual care, negative framing, it all doesn't make a big difference, but we need to make sure that early on, in the first couple of weeks, patients on CPAP therapy get on well, have the right kind of interaction with the technicians, the doctor, the center, and to get over their anxieties and try to optimize their usage. So maybe that as much from my side. We're already over time. Esther, any other questions?
I think we have answered them all.
We've answered them all.
I hope so.
I hope you're not all speechless. Great. In that case, before we have now a well-deserved weekend, back to the last message. So first of all, I am thrilled that we had a big turnout and a big interest in the clinical update Sleep, even though it is just a virtual and a very shortened program. I want to, of course, thank all the speakers. We've learned about cardiovascular interaction in sleep apnea and CPAP. We've learned about the pandemic lockdown and the effect on sleep, not only in the patients, but in the general population. We've learned about the insomnia and hyperarousal and the effort to really stem the demand of patients that have flooded in not only this year, but previously as well, to be seen and to be taken seriously. And then, of course, we have many more informative data points in the journal to read about, and I would be grateful if we get in March the chance again to discuss these things further. So if you've enjoyed this, if you like sleep, spread the word, come and join us in March. Keep an eye out for how we're going to deliver this. I can't promise you at the moment anything, understandably, but we will deliver it. Virtually, hybrid, or in person, we're going to get there. I wish you all to stay safe. I want to thank not only the speakers, but also the audience for the engagement, and the organizers, that is the GSTT events team, Danny in the background, and her team, of course, and all the sponsors who kindly just postponed everything to March. So stay well. If you've got the one or other hour over the dark winter time where you are in lockdown, fingers crossed, hopefully not, but read some of the journal, get back to us, feedback to us. You will get CPD points for this event, and we look always forward to hear your feedback to see what we can further improve. So thank you very much. Esther, thanks for co-chairing, of course, and wherever you are, stay safe and enjoy the weekend.